Okay, let's set the scene. It's 2 in the morning. You're the only doctor covering two, very busy medical wards.
A familiar feeling for many.
Right. And on your screen, you've got this stack of time-critical IV antibiotics due. Basically now, they need your immediate attention. But at the same time, the nursing staff are asking about a set of routine bloods that still need taking.
Yeah.
And then a final-year medical student comes up to you.
Yes. The keen student.
Exactly. Keen, motivated, and they ask if they can practice placing a cannula on Mrs. Jones, who is, of course, a confused, complex patient, known for having notoriously difficult veins.
That is the perfect storm, isn't it? It's a classic high-stakes, low-resource environment that, it just perfectly captures professional life and the scenarios you see in these high-stakes assessments like the situational judgment test or SJT.
Absolutely. The tension is real. So what do you do first? Who is the right person for which task? And I guess, most importantly, how do you make absolutely sure that delegation doesn't lead to some kind of patient safety disaster? Okay, let's unpack this. This deep dive is all about mastering delegation and supervision, a skill that is, it's just essential for patient safety and a core expectation from the General Medical Council, the GMC.
And the mission here isn't just to, memorize a checklist for an exam. It's to fundamentally get the underlying legal and ethical architecture of accountability.
Right.
Safe delegation isn't about just offloading work because you're swamped. It is about managing risk and managing it effectively.
So if there's one central guiding principle we need to internalize right now, what is it?
The central exam truth is this. Safety always comes first. You have to match the task to a competent person, give crystal clear instructions, supervise appropriately for the level of risk, and this is key, record who owns what by when.
That structure.
That structure is what keeps you, and more importantly, the patient, safe.
And we're spending serious time on this because the consequences of getting it wrong are just so severe, aren't they?
Exactly. Unstructured or, unclear delegation is a primary cause of omissions, critical delays in treatment, and ultimately patient harm. So we are going to synthesize the frameworks that keep you GMC compliant. And you will always score highest in these professional scenarios when you pick the options that show safety, clarity, and accountability.
Let's start with the basics then, the definitions, because the distinction here feels really key. What's the fundamental difference between delegation and just asking a colleague to do something for you?
It's all about the transfer of authority versus the retention of responsibility.
Okay.
So delegation is asking someone else to perform a task. Let's say taking a difficult set of bloods. The crucial part, though, is that you, the professional who assigned it, you retain the ultimate responsibility for ensuring it's done safely and that the outcome is reviewed and acted upon.
So even if I delegate a routine task to a fully trained nurse, if my instructions were vague like, can you check the vitals soon,
Right.
and they miss something critical because of that vagueness, the buck still stops with me.
The buck absolutely stops with your lack of oversight. And that's where supervision comes in. Supervision is your active mechanism for managing that responsibility you've kept.
Okay.
It means providing the right level of oversight, support, and review. And that level, it has to be tailored to two things: the risk of the task itself and the competence of the person doing it.
And this is where the high-yield material comes in, because the GMC doesn't just leave this to chance. They lay out the non-negotiables, right?
They do.
So what are those core requirements we need to hit every single time?
Well, the source material is very clear on this. First and foremost, patient safety has to be your overriding concern. You only delegate when you are certain it's safe for that specific patient.
Right. That's the foundation. What's the next critical step that people get caught out on in these high-pressure moments?
It's the competence check. This is where assumptions just lead to failure. You have to actively, explicitly check the competence, the training, and the documented scope of practice of the person you're delegating to.
So don't assume.
Don't assume that just because someone wears a certain uniform, a newly rotated doctor, a senior HCA, that they're automatically signed off for every procedure. You have to ask.
That is such a classic trap. You might think the HCA has done 1 million ECGs, but if they haven't been formally signed off at your hospital, delegating the tracing is unsafe.
Precisely. The third pillar is communication. You must give clear, concise instructions. And that's not just what to do, but when to do it, and the explicit parameters for when to escalate. We call it closed-loop communication. You confirm they understand the task and the escalation triggers.
And the final expectation,
Right.
oversight and documentation, I'm guessing.
Exactly. You have to provide accessible supervision. You need to be available for advice or for immediate intervention if things go wrong. And crucially, you must keep clear, contemporaneous records of what was delegated, to whom, with what plan, and the time frame, if it's not documented.
It basically vanished into the 2 a.m. air.
It never happened.
Okay, I get the definitions and the GMC rules, but when I'm running around at 2 in the morning, I need a quick structure that stops me from making those dangerous assumptions.
It sounds like a lot to hold in your head.
It is, and that's why we rely on frameworks. Structure reduces stress and prevents you from missing a step. The highest yield approach is often called the 5 rights of delegation. If you follow these 5, you automatically cover the GMC requirements.
Okay, let's walk through them. Where do we start?
You start with the right task. Is this task generally something you can delegate for this specific patient? Simple bloods? Probably yes. Titrating an inotrope for a patient in septic shock? Absolutely not. The risk must be acceptable.
Okay, that makes sense.
Second, the right person. We've touched on this. You confirm their skills, their training, their authorization. This is where you pause and specifically ask, are you signed off for this?
That's the barrier against unsafe practice.
It is. Next, making sure they know exactly what to do.
The right instruction. Yep. Specificity prevents errors. So you give the task, the time limit, and the safety net. For example, take the blood gas, but call me immediately if the pH is below 7.2 or if the lactate is over 2.
And for anyone listening who isn't in acute medicine, a rising lactate, or lactic acid, is a huge red flag that a patient might be going into shock, right?
A massive red flag, exactly. That context is vital. So once the instructions are clear, then it's about managing your own presence.
So, the right supervision.
Right. You decide the level of oversight. Are you watching directly? Are you on the ward and just checking in indirect? Or are you contactable remotely? You have to be clear about your availability and make sure you review the outcome.
And finally, tying it all together.
The right record. You document the plan, the specific person who owns the task, the deadline, and those crucial escalation triggers you talked about. This makes sure accountability doesn't just disappear when the shifts change.
That's a really solid framework. Now, for rapid retention, the source material has those mnemonics. There's the shorter one, but let's quickly go through the longer one, delegate.
Yeah, delegate covers every step. Define the task, evaluate competence, level of supervision, explain and check back. That's your closed-loop communication. Give resources, make sure they have what they need, agree times, track the outcome, and finally, enter it in the record.
So using these frameworks, you hit every single GMC requirement, and you turn a chaotic high-pressure moment into a structured, safe decision. Okay, let's switch gears and talk about the mistakes.
Yeah.
The things that will get you into trouble. The SJT format is, it's designed to tempt you with options that put speed over safety.
The decoy detectors.
Exactly. What are the common pitfalls that cost points and, more importantly, could harm patients?
Well, the first trap is definitely prioritizing speed over competence. So an option that says something like, I'm busy, let the new intern have a go at the central line, it's good experience.
Yeah, that's not bad.
It's terrible. It's unsafe, unsupervised practice for the sake of speed. You cannot delegate a high-risk procedure where competence hasn't been established.
So if a choice relies on the phrase, I assume, or they should know how, that's almost certainly the wrong answer.
Precisely. That's the second big trap, assuming competence. Ask the HCA, I assume they can get the blow gas. You have to reject that option because it completely ignores the right person check. You must confirm.
Okay, what about communication errors?
The third trap is just vagueness. Any option that sounds like, just keep an eye on Mrs. Smith or sort that out whenever you get a minute, that's just poor practice.
Because there's no owner, no time frame.
No specific task, no escalation parameters. Vague tasks are forgotten tasks.
And the fourth trap, it's about accountability and, I guess, modern tech.
Yeah, governance failure. An option like delegate the task on WhatsApp and don't bother with the notes, I'll sign it later. That completely breaches accountability. You need a clear, contemporaneous, formal record. You need an audit trail.
Right. So now let's talk about the red flags. The scenarios where you absolutely cannot delegate, where you have to intervene yourself or escalate immediately.
If you see any of these, you stop and you act. First, any invasive or high-risk procedure that's clearly beyond the delegate's established scope, you cannot ask a student to put in a chest drain.
Obvious when you say it like that.
Second, if time-critical therapy, like those IV antibiotics, is at genuine risk of delay, you have to step in and give it yourself.
So if patient safety is on the clock, you don't delegate that critical first step.
Exactly. Third, rapidly deteriorating observations where there's no clear plan or owner. And fourth, any unsupervised student request, especially for a complex patient or at night when your own availability is limited.
The roll down is pretty simple. If safety is uncertain or competence is unknown, you either do it yourself or you escalate to a senior. And then you organize proper supervision. You never delegate unsafely just because you're stressed. Okay, let's put these frameworks to the test. Let's dive back into our 2 a.m. scenario, the student cannulation. Final year medical student wants to cannulate a confused patient, bad veins, 2 in the morning. You're covering 2 wards. We know the wrong answer is just letting them do it. So what's the highest scoring action?
The highest scoring option has to meet the right supervision and right person rules. So you must assess the student's experience, get patient consent, and then you either supervise directly yourself or you reallocate the task to someone you know is competent, like a senior nurse or another doctor.
And you document it.
And you crucially document the whole plan, including the escalation criteria.
So the rationale is that complexity plus time pressure plus compromised supervision just equals a definite no to unsupervised student practice.
Spot on. Now, let's look at that classic prioritization problem. Scenario 2. Limited staff, 5 tasks you got. 1, time-critical IV antibiotics. 2, new delirium needing a capacity assessment. 3, routine bloods. 4, a cannula for CT contrast. And 5, a discharge letter. How do you rank them?
This is where stress can lead to failure if you don't have that structure. We've got to rank them from, do it now, highest priority, down to lowest.
Okay, so you start with the most immediate threat to life. That's the time-critical therapy. So highest priority is D. Personally prescribe and give the time-critical IV antibiotic now. You have to start the treatment yourself to guarantee it happens on time. Then you can delegate monitoring.
Okay. Safety first. What's the next immediate threat?
The patient's changing status. So second priority is A. Personally review the high-risk delirious patient now. They need a rapid assessment to find the cause. You do the critical thinking, but you can safely delegate gathering collateral information to a competent staff member.
Right. Now we're moving to the necessary but less acute stuff.
Exactly. Third is low-risk necessary work. So B, delegate routine, low-risk work, like those blood tests, to a competent person with clear instructions and a hard deadline. That is perfect, safe delegation.
And the admin task.
Fourth is E, write the discharge letter. Paperwork always comes after immediate clinical safety. It's important, but it's not life-threatening.
Which leaves the lowest scoring action, the unsafe option.
Which is C. Never ask a student to insert a cannula for CT contrast unsupervised.
Right.
That is the definition of unsafe delegation. It's a high-pressure cannula, maybe for a pump. It requires a competency a student just won't have. It violates the right tasks and right person rules.
The logic is always safety over speed.
Always.
Okay, so to really build confidence, what's the actual language people should be using? What are the model phrases that demonstrate competence?
You should always lead with an assumption check and a specific boundary. Something like, are you signed off for this? Okay, here are the escalation triggers. Call me immediately if the patient's systolic drops below 100, or if you can't get the cannula in after 2 tries. The deadline for this is 2 p.m.
And you link that back to the record.
Absolutely. I'm documenting that you'll take the FBC and UNEs by 2 o'clock. I'll re-review the results at 3, but message me sooner if you see any red flags on the chart. That language just screams closed-loop communication, an explicit deadline, and safety netting. That's a high-scoring answer. So before we wrap up, let's just consolidate those key actions. There are really 3 things to remember.
Okay. First, we have to remember that safety beats speed in every single delegation decision.
Every time. And second, we have to confirm competence and authorization before allocating any task. No assumption.
And finally, we set clear review times and escalation thresholds and always document the owner, the deadline, and the supervision plan.
You master those rules, and you master a critical pillar of patient safety.
We've established pretty clearly that delegating a task doesn't remove your professional responsibility at all, which I think raises an important question for you to carry forward into your practice. When delegation does fail, and sometimes it will, how much of that failure is due to poor supervision or unclear instructions, and how much of it is due to a lack of your own self-awareness about the risk you took in the first place?
That's a powerful thought.
It's something to keep in mind as you explore the related topics of safe handover and escalating clinical concerns.
Understanding those boundaries of risk and self-awareness really is the hallmark of a safe and effective professional.
That was our deep dive into the 5 rights of delegation and supervision. We hope you feel much more informed and ready to apply that knowledge safely.